Good afternoon, and welcome to the 10 Things That Keep Physicians Awake at Night, a State of the Union about the United States healthcare system and the effect on physician offices. My name is Colby Dix, and I will serve as moderator today for our Care 360 sponsored webinar. Just a quick bit of housekeeping. There will be a brief poll and a Q&A directly following the main presentation. Please feel free to use the built-in WebEx Q&A box to submit any questions during the seminar, and we'll do our best to get to them all in the time allotted. If for any reason we don't have sufficient time, rest assured that either Mark or a Care 360 representative will answer you directly offline. As well, a PDF version of the slide deck will be included in your follow-up email for your future reference, and will also include contact information for all of our presenters today. We're very excited to have special guest speaker Mr. Mark Anderson with us today, whose 40-plus years in healthcare IT have brought him a wealth of knowledge across a great deal of the topics that concern all of us in the industry. He's a highly respected consultant to over 25,000 physicians and 200 hospitals nationwide, and we're very lucky to have him. So welcome, Mark Anderson.
Well, thank you very much for inviting me to speak today, and hopefully everybody's having a good day so far. We're going to cover a few things during this session. We've done a number of studies on the top 10 things that really keep patients awake at night, issues that are really affecting them, and I'm going to talk about those 10 things just to give you an idea of what other physicians are facing. And you may or may not be facing the same items, but I believe a lot of these issues that we're going to talk about today are things that are probably dear to your heart. And then we're going to talk a little bit about this new movement from fee-for-service reimbursement systems to quality or value-based reimbursement. And we'll explain a lot of this later. But the Medicare, Medicaid, and all the healthcare plans are planning on changing the way they reimburse hospitals and physicians away from fee-for-service to a quality-based, as they call it, value-based reimbursement model in 2018. And I'm going to explain more about what that really is and how it really affects you as you go forward. So let's talk about the 10 things that keep people up at night today. This is a number of surveys that have been done by other organizations, HPMA, MGMA, American Hospital Association, our own internal surveys, and also there's been some new surveys that have come out from the American Medical Society. But this is kind of like a summary of all those wrapped together. So 62% of all physicians that participated in the survey mentioned that they're worried about the changing reimbursement model. And as I mentioned, going from fee-for-service, in 2015, it was about 92% of the money most doctors got came from fee-for-service, to a value-based model based on quality and outcomes, which is they're planning on moving to 50% by 2018. I'm not sure if we'll get there by 2018, but between 2018 and 2020, 50% of all of the money you get reimbursed by the healthcare plans will be based on quality, no longer based on fee-for-service or the number of CPT codes that you submit to the insurance plans. And a lot of people don't know what that means. They don't know how it's going to affect them. But as I mentioned, we'll talk about that a little bit later. The second area is 58% of the doctors said they're really worried about high-deductible insurance plans. These are insurance plans where the deductible went from, say, $500 a year or $1,000 a year to $7,500 a year for high deductibles. And because of that, the amount of money that patients pay towards their care on average went from 5.8% in 2000 to over 23% in 2015. And what that really means, your office staff has to do a much better job of collecting from the actual patients. Yeah, the insurance company may have accepted your claim, may have approved the claim. That claim may have been for $2,000 worth of surgical work, but all of it goes to the deductible. How well are doctors' offices set up to collect money from patients, either upfront or within the next, after the services are rendered or within 2 or 3 billing cycles? The change is really affecting how physician offices are operating, because if you look at your overall money, you can be talking about an 18% decrease in income if you don't handle the way you process patient payments better than you did back in 2010. So a big issue, everybody's looking at that. Another issue has been 42% of the physicians have said claim denials have increased dramatically. And again, the survey showed that about 12% of all claims that were submitted in 2010 ended up being denied by the insurance company for various reasons that are out there. But that's now up to 23% in 2015. So it's almost doubled the number of denials that health insurance plans are handling on your claims going out. And as we all know, if you look at the staff it takes and how much time it takes for the staff to handle those denials, that's like $25 per denial. So you start looking at how much cost that you have to pay for your office staff. You may have actually hired additional office staff, or maybe you've contracted it out. But the cost for collecting for services already rendered by you is going up. And denials is a big factor for that. And like I say, there's probably 200 reasons for denials. Your office manager should be telling you exactly how many denials you have per month, what the percentage are by type of denials, and by the insurance company. You need to make sure that you're cutting down the number of denials you can as fast as you can, because you know a denied service means no payment. And even if that payment is legitimate, if you don't respond to that denial adequately within 30 to 45 days, you'll never be able to collect on that denial. You have a limited amount of time to collect money from any denial out there. You need to make sure your office staff are really following through on that very effectively. The fourth item that's out there that people are really worried about, and I hear this from a lot of physicians, 38% of all the doctors said that they're not happy with their electronic health record selection. They don't like the software. It's too time-consuming. It really provides no value to them. And we've also heard that a lot of the software companies are going out of business. They're not selling their software anymore. They call sunsetting the software. And a lot of doctors are very frustrated because they bought a system maybe 3 or 4 years ago, and that software product is no longer supported. I have a number of doctors that bought a product that met the stage 1 requirement, and then that product was not upgraded to meet the stage 2 requirements. And as we all know, some type of stage 3, although they're changing the initials for that, there's going to be a new standard coming out next year. Will your product be able to meet those requirements? Not if the company goes under, not if the company decides they're not going to support it anymore. So you got 38% of the doctors are unhappy. They want to replace it with something else. And a lot of doctors just don't see the value in having an EHR. So if you've got a product you're not happy with, what do you do? And what do you do if you have a software product you're not happy with and the software vendor sold your contract to a bank and you still got to pay the bank for 3 or 4 more years? Now, there's revenues out there for that. We've done a number of cases, lawsuits with doctors, helping them getting out of these contracts, but it's a big concern for them. Number 5 is kind of interesting. As we move towards quality-based reimbursement and outcomes, and you're reimbursed based on these outcomes, what do you do with non-compliant patients? Patients that will not follow your protocols, patients that won't pick up their medications or won't take the medications when you tell them, patients who will not go in and get the tests that you recommended, maybe because they have a high deductible. If your reimbursement changes in the future based on how well the patient recovers from an injury or an issue, and the patient's not compliant, what do? You don't want to have your whole income, or say 50% of your income, being held up because patients are not compliant. There's a lot of things we can be doing. A lot of this deals with care coordination and care coordinators. Doctors don't have time to spend trying to make the patients compliant, but maybe there's another type of people that could. The more the care coordinators help coordinate the care, who call the patient to remind them that why it's so important to get things done. But again, it's the 5th biggest issue out there today. Number 6, 28% of the doctors said are really questioning, should they stay independent or should they just go ahead and join the local hospital? As we said in my profile, I've worked in a lot of hospitals at corporate office. I've worked for over 250 hospitals. And I think hospitals do a really good job running hospitals, but they really don't necessarily understand the physician mentality. My belief is a hospital is just another place the doctors come and treat patients. The hospital is not the center of the attention. The doctor is. If the doctor want to work in their office, the hospital, ambulatory surgical center, outpatient center, You are the ones driving all the business. We have no business in a hospital unless you bring business to us. Yes, we have patients in the emergency room, but we have to have doctors to treat those patients. So I always say try to stay independent if you can. If you want to join a hospital, I think that's great. But I think doctors who join together into an independent physician association, an IPA, or join an MSO, management service organization, that allows you to stay totally independent, but still bring your power together, a group of doctors, to really figure out what do you need? What do you need for your practice, and what do your patients need? Number 7, 15% of the physicians are really worried about the consolidation of major payers and how it might affect their income. We've seen the articles, the discussions out there where one large healthcare plan is buying another large healthcare plan. We may be down to 4 or 5 large healthcare plans that really cover 60 to 70% of the non-Medicare and Medicaid patients out there. And what happens if you don't have a contract with them? What happens if Aetna has decided not to have you part of their profile, and now they are twice as big as they were in the past? What happens if United does the same thing? You can be hurt because the healthcare plans are combining, becoming bigger and stronger, which gives them more power to really control contracts, and then they decide which physicians will be on their panels, and you may be left out of those panels. So again, that's why a lot of doctors are concerned. 15% are concerned about it, but I think as consolidation occurs, more doctors will be concerned about that issue. Number 8, this is an interesting one because we haven't really talked about this too much in the past, but we're hearing about the cybersecurity break-ins where people are breaking into hospitals and physician systems. And the new one is, how do I protect my clinical data from hackers and what's called ransomware? You may not have heard about some of these things, but there's been a number of cases where a hacker breaks into your clinical EHR and puts a secured password that you cannot get in to see any of the patient's data. It basically blocks you out unless you pay them a ransom fee for them to take off that block. That is it's only 14% of the physicians today, but we're seeing more and more of those. And it's interesting, the first hospital that ever paid ransom to get access to their data was the first hospital I worked in back in 1972, where obviously they did not have the right securities today to block a hacker from getting in and locking down all information so that no doctor, no nurse could view any information about the patient unless they paid a fee. Again, it's a ransom. Number 9, 12% of the physicians stated, with the changes in meaningful use requirements, especially in stage 2 and now going forward with the next stage, and the elimination of the financial incentives, there's not much financial incentive to use these systems anymore as far as additional pay. Does it really matter anymore? The penalties are slow coming. The penalties are low. If you bought an EHR and it's really slowing you down, should you stop using it? Answer is probably no. But the information, the value is really out there by having the information. But for a lot of doctors, they don't necessarily see the value for them anymore because there's no incentive payment. The main thing is to make sure you've gotten an EHR that you like, that saves you time, and you see value in. And if you don't, maybe consider looking for a different product because you are going to have EHRs going forward. One primary reason is we believe most of your malpractice companies will require it because we know that physicians that are using EHRs have less issues with malpractice because the system gives you alerts, it gives you more protection from malpractice. So you're going to have these systems, but get a system you like. And again, if you're on a system today that you don't like and you don't think you can get out of the contract, I guarantee you can. We've gotten hundreds of practices out of contracts that they didn't think they could break. They're breakable. And the 10th item, we're finding number 11% of doctors said it's harder for them to find young talent to supplement the physicians at lower costs, hiring PAs, nurse practitioners, clinical coordinators, and the like. Yes, we can find nurses, we can find nurses' aides, but we're having a hard time finding qualified PAs or nurse practitioners because there's such a large demand for that today. The schools are not producing as many as PAs and nurse practitioners as needed based on the volume that's going on. So you end up spending more time and more money trying to find qualified people, and they're out there. But it is becoming a bigger issue for a lot of groups that are trying to expand their offerings, trying to expand how many patients they can see at a lower cost without hiring additional physicians. So that's the top 10 things that doctors are facing today that kind of keep them up at night. Hopefully some of these are the ones that you're at least also worried about too, to provide some value for you. Later on, maybe other sessions, we'll be happy to provide additional information about any of these 10. But today I want to kind of transition over to the very first issues I mentioned, which is a changing reimbursement model, so you can get a better idea of how it might affect you if you really don't know about it. And what we're talking here about is the new reimbursement model that's moving payments from fee-for-service to a value-based reimbursement model, primarily for patients that have chronic diseases. But, it's a new reimbursement model. We're going to talk about when does it start, when it may affect you. And a little bit about why they're changing the reimbursement model. It's always good to know why governments and the healthcare plans are doing this, but it will affect your revenues. And I want to make sure you understand how it will affect it. And then the last part we're going to talk about today is what software is really needed. What are the requirements? What's the functionality that you need in your software so you can meet all the requirements going forward with value-based reimbursement? And you'll see a lot of the initials VBR. For some reason in healthcare, we like using 3 initials for everything. I think it might have started with IBM way back when. Most don't even know what the initials stand for. But you'll see the initials VBR for value-based reimbursement in a lot of articles out there today and things coming forward. But what is value-based reimbursement? Again, as I mentioned, we're moving to accountable care for patients with chronic diseases. About 38% of the population today has some kind of chronic disease, but they're generating about 65% of all the cost. And Medicare originally started this process when the CMS established accountable care organizations back in 2009. I believe there was 83 originally. Between Medicare and the healthcare plans, there's over 425 certified accountable care organizations out there today that are working and getting paid based on quality instead of fixed reimbursement. The payments are based on quality improvement and improved outcomes, not for doing the work, not how many x-rays you order or how many patients you saw, but actually the number of patients where you can prove that you're improving the overall lifestyle and quality of that patient and improving outcomes based on what the government and these insurance plans designate as what they think the outcomes are. And today it only includes patients with chronic diseases. So it's not people that are healthy, it's not people who are in car accidents, it's people that have designated chronic diseases today because, again, larger population and is driving a lot of the cost. And how do we know all this? Well, look at this is a press release that came back out in January 26 of 2015. This was their plan, that by late 2016, they're planning on moving 30% of all payments for traditional or fee-for-service Medicare payments to this alternative model. And they believe by 2018, 50% of all the payments will be moved towards this kind of a new reimbursement model. After they announced this in, I'd say, mid-2015 through early 2016, 7 of the largest healthcare plans that represent about 75% of the non-Medicare Medicaid business have also said the same thing. They plan on moving to this model, which will, again, affect up to 50% of all payments to doctors and hospitals in 2018. Moving to the next slide. Hopefully moving to the next slide, let's put it that way. There we go. Had a hard time getting it to move. If you go back and look at the break in fee-for-service in 2010 and what we're looking at probably by 2020, you can see the breakdown of the payments. Heavy fee-for-service back in 2010, over 83%, with a small amount of money being paid for episodic care, condition-based care. But as you can see how fast it's moving, that in 2020, fee-for-service will be very low. They're really looking for physicians that can really manage the population of those patients, or partial populations. And they're going to make sure all this is done effectively, low cost, and in this case, the government or the healthcare plans will decide which physician to work with. And as we move to this new model, we have to make sure you're prepared for that. One of the reasons why we're moving to this new reimbursement system is because the government and healthcare plans, everybody else is saying, our overall costs are much higher than other countries. Now, when you really break it down and you look at by age population, our cost per capita by age is about the same as everybody else until you hit around 55 years. And you start looking after that, our costs go up dramatically per capita, per person. Now, why is that important? Obviously, we have Medicare for people over 65. But why are we spending, in some cases, 10 times more for patients that are in their 90s than other countries do? That's a big issue for things. It's not that our cost is much higher. It's not that doctors are doing a lot more business, for younger people. We're pretty in line with everybody else. It's the patients over 55. We're doing a lot more work than other countries. And I think that's one of the things the government's not talking about. They just keep talking about how costs are going up. And that's because we have an aging population. More and more people are in their 60s, 70s, 80s, and 90s than we ever did. Remember, in 1965, when Medicare started, the average life expectancy was only 65. And that's what the age was when you got on Medicare. Now the average life expectancy is almost 85, 20 years longer than ever expected, but the age for getting on Medicare never changed. Therefore, we have a lot more people on Medicare. Therefore, we're spending a lot more money on Medicare, not because the costs have gone up, because there's more people on Medicare. But still, we need to change. The government wants us to cut that cost down, but they really have to understand why the costs are going up. One of the other problems we run into is that there's all kind of great statistics out there and quality improvement programs around making sure you provide the right quality indicators and make sure the patients are compliant with those quality indicators. And you start looking at certain things like breast cancer, prenatal care, low back pain. We're doing pretty good as far as meeting a lot of those clinical indicators that are out there. But you start looking down at the bottom, there's a lot of diseases where we're not very good at getting the patients to be compliant with the indicators that are out there. And overall, we're only at about 55% of all adults meet the requirements that the doctors have set for them. So we have to find ways of helping the patients follow their clinical protocols better. And again, we're now putting the incentives to the doctors from a financial point of view to follow those protocols as we go forward. You get paid based on how well those patients meet those protocols. Of course, if you have non-compliant patients, it's going to affect your income too. But this is why they're moving towards that model. The other reason they're moving to a model for the new value-based reimbursement for chronic disease patients is just the increase in people with chronic diseases. By 2030, we're predicting that patients, United States patients with a chronic disease will reach 171 million people. Today, we're already broke 150 million people have some kind of chronic disease today. These are the people that are driving healthcare costs up much higher because they use a lot more healthcare. The average healthy person uses less than $1,000 a year. The average chronic disease patient is spending over $10,000 a year for care. That's why they want to start looking at how can we work with people with chronic diseases to reduce their care, and they're putting all the pressure on the physicians to create better models for improving the overall health of patients that have chronic diseases, but primarily reduce the cost for that care. Now, what do you need as a physician out there or an office manager to be able to compete for value-based contracts? This is a tough one because the majority of the contracts are going to go to large integrated delivery networks of hospitals and doctors. And that's going to require that the hospitals partner with enough primary care physicians and other clinicians to provide comprehensive preventive and chronic care. Hospitals are going to be coming to you and saying, we want you to participate in our program. We want you to agree to be paid based on a new quality reimbursement versus fixed fee reimbursement. Therefore, the hospitals and the healthcare plans have to find a new way of really reconstructing the physician's compensation to align provider incentives with this value-based care. No longer providing reimbursement or incentives, or if you want to call it, for ordering more tests, getting more things done, seeing the patient more. Now it's all about what can I do to keep this person healthy, primarily to keep them out of the hospital. Do you realize for one emergency room visit cost, I can have 32 additional physician office visits for that same price? We're better off the patients coming to the doctor than showing up in the emergency room because of the price structure there. So it's better for us to find a way for that patient, take a diabetic patient, get them to come to the doctor's office more often, and one less emergency room visit will pay for a whole year's worth of doctor's visits. That's one of the models everybody's looking for. We also have to find ways of creating what they're calling patient-centered medical homes, or use existing patient-centered medical homes for building blocks for creating an accountable care organization, an ACO, because those are the organizations that are traditionally going to get these value-based contracts that the healthcare plans and CMS through Medicare are going to be giving out. But everybody needs to focus on care management for those high-risk patients, as well as any segment of the population that could become high risk in the future. The best example of that is childhood obesity. We know that the number of kids that are classified as obese is increasing tremendously every single year. And I'm based in Houston, Texas, and I think the last 3 years, Houston has been labeled, they call it the fattest city in the world, but I think it's more, when we look at the obesity rate, we have a very high obesity. We know kids that have obesity are going to be diabetic patients. They're going to have CHF problems. They're going to have asthma issues. They're going to have COPD issues in the future. They're going to have multiple issues. We need to start working with them to keep them out of that high risk. We also have to find automated ways for calculating information about the population and really creating risk stratification to find out what is it costing for these patients, which contracts we want to bid on, and are we able to save money in a healthcare organization by taking on some of these value-based contracts? Because if all of a sudden you take on a lot of high-risk patients, you're going to have a lot of cost. We have to know what's the risk stratification of that population. What percentage of the diabetic patients are at high risk? What percentage of the diabetic patients are at low risk? That's going to affect how well an organization can thrive in a value-based market or go under a value-based market. Plus, what everybody is saying today, we need to embed what's called care managers in practice. These can be nurses. They could be people who really just don't want to provide direct hands-on care, but they create a really good way of creating the relationship with the patient. This is where somebody's calling the patient, calling their family, just checking on them to make sure how they're doing. Are they taking their medications? Remember, the more contact you have with the patient, the more ability you're going to know how that patient is compliant with the requirements that you provided for their care plan. So with all of this, and if you think about, bidding on some of these value-based contracts, or if the hospital's bid on them, they win, and you're participating in, what software are you going to have that meets this? Now, one of the biggest challenges is that if you look at the ACOs today that are out there that are successful, they have one single software product that handles their clinical and financial data. It could be a truly integrated product, or it could be an interface, but all of the data is stored in one place for clinical and financial analysis. You need to have some kind of care coordination software and services. Somebody's going to have to coordinate this care. The best example there is somebody's calling the patient at home, calling their family. They find out the patient's having issues. They coordinate between the family, and that care coordinator then coordinates office visits for the patient to come to see you. You don't have time to spend all, coordinating all this care. A care coordinator will be doing that for you. You need population health management software out there. A lot of people are talking about that today, to figure out what the population is and how to manage them. You need software that helps you engage the patient. Collecting information from the patient from their home is very valuable. If the patient only sees you once every 3 months, you're going to get a little bit of information. But if we have ways today that can capture information from the home about what the patient's doing, did they take their medication, what was their vital signs, and have that sent to a care coordinator, they can create alerts and let you know if a patient's no longer following the protocol or having issues. We need best practice clinical guidelines and exception reporting for clinical alerts. Main thing is to provide care knowledge back to the provider. Tell me what I need to do with the top 5 patients that make the biggest difference. Don't bother telling me that I have 95% of my patients are on protocol. Tell me the 5% that are not. So clinical alerts, best practices, and providing that information back to the doctor at the point of care, or maybe even on their smartphone, maybe it alerts that way. Bottom line is you have to have a way of financially modeling this system and doing risk stratification, because if you're going to get involved in value-based reimbursement, you don't want to lose money on it. You'll want to be able to at least make as much money as you are today, and some of the organizations I've seen, they're actually making more money going forward under a value-based contract. So how do you do all this? To me, it's really about coordinating the care between all the providers in the community. It cannot be one doctor working with one patient and that patient goes to 4 other doctors. We need to connect the physicians, the pharmacies, the payers, the patients and their family, home care providers, long-term care providers, and the employers. Bring everything together into a way where we can actually look and coordinate all the information about the patient, their clinical data, with physician portals, so the data can be shared between all providers that are treating that patient. Something we've been talking about for a while. We really do need to move towards that. And the ACO community is the best connected to do that today because they have the ability to connect the community together. And really, with the start thinking about the value out there, there's a lot of value in sharing information about the patient between providers. Really, 65% of the value of sharing is provider to provider. We create a little bit of value of sharing the data about the physician to the hospital, especially when the patient comes into the emergency room. It's nice to have emergency room doctors that have access to this information. Today, most of the emphasis has been on having the hospital provide data back to the physicians. That only creates about 10% of the overall value. The real value in sharing data is between the primary care doctor, the family physician, the internal medicine doctor, with the cardiologist, the GI doctor, the endocrinologist. It's sharing data between all of them. Everybody that the patient is being treated by today and in the future, that's the value of sharing data. So the hospitals are not the center of everything, the physicians are. And an ACO model, an IPA model, where you're working together with IPAs and other physicians to share data creates the best value today. And I've worked at hospitals and IPAs, so we see the value for all of that. So value-based reimbursement requires more than just tracking of the health of a specific population. And I'm not going to go through all these because these are the different functions that are required for value-based reimbursement. Obviously, the core of all this is having some kind of system at the bottom, it's your electronic health record system, and patient demographics, having all that available. But if I've got a patient who's going to 5 doctors and their names are spelled differently, one has an initial, one does not have initial, we have to have the way of having a master patient index so I can bring all of the data about that patient into a single view of all patient data at any time, at any place, on any device for those physicians. That's the beginning part of all this. If I can't bring all the data together, there's no way of treating the patient. And the rest of the things come longer, much longer down the path as we look to moving towards value-based reimbursement by 2018. But things you need to think about, you have to have a good EHR that's going to be shareable of information so that they create one single view of that patient's overall medical condition. Took a while for me to go to the last slide. Sorry, but conclusion. Don't worry about the little things. there's enough big items out there to really keep you up at night as it is. As I mentioned, and most of the presentation was about this new healthcare reimbursement model is changing away from fee-for-service to value-based reimbursement. It's already begun, but in 2018 is when everybody's saying it's going to become fully operational, and that will potentially affect 50% of your reimbursement, 50% of your income. If you're not participating in these value-based contracts and any of your patients have chronic diseases, those patients could be sent to a different physician that is participating in those models. To compete in this new market, you really need to find ways of partnering with hospitals to generate a true next-generation enterprise-wide technology built by physicians and clinicians for clinicians and physicians. You don't have to have the same product that the hospital is using. Most hospitals may be on Epic, Cerner, Allscripts, Meditech or whatever, but your software product has to be able to interface directly with that. Two ways, data going into theirs and their data coming into you, so you can share all that information. If you cannot share information, they will not invite you to participate in these value-based contracts. So by 2018, either move your technology to enable value-based reimbursement systems or join a large IDN and lose your independence. And I think a lot of doctors, especially the ones that have been in business for 5, 10, 15, 50 years, don't want to be losing their independence. Once you're independent, you want to stay independent. And you have to be thinking about these things if you want to stay independent going forward in the near future. With that, I'm going to open up to the poll and questions. Colby, you want to take over?
Absolutely. Thank you so much, Mark. That was an outstanding presentation. A lot of great information there. We're going to open up the poll here first for all the live attendees today. If you'll take a brief moment to take a look at just 2 questions there. Very simple enough to answer, I believe. And as well, just to remind you, if you're watching WebEx within windowed mode, on the right side there's a Q&A box where you can type in your question and hit send. And if you don't see it, you can click on the Q&A icon at the top right to make it appear. If you're in full screen mode, there's a Q&A button within the controls at the top of your screen. So please stay with us after the Q&A section in the poll for a very brief presentation of Care 360 and our complete suite of healthcare IT solutions that are designed to increase the efficiency of your practice. We'll let the poll run for a couple more minutes. I do have a Q&A already available here that came in during the presentation, Mark, if you don't mind. I'll hit you up with the first one that says, we are a 2-provider practice and are considering joining an independent physician association. What red flags should we be looking out for?
A couple things I would look for, and I've worked with probably 30 different IPAs in the past. What you really want to understand is a couple things. One, who manages and runs the IPA? There's a number of IPAs that are managed and really controlled by a local hospital. You're basically working for the hospital then, but they're doing it through an IPA association. That's kind of a red flag. I like IPAs that are totally independent. I worked with the Taconic IPA up in Upper New York. They had 2,300 doctors, and they basically created the control over what was happening in that community of 10 hospitals. They decided they were going to bring their own software in. They decided which hospitals they wanted to work with, and they basically made the hospitals meet the physician's requirements. So look for independence of the IPA, who owns them, who runs it, and especially if you're a specialist. Is the IPA designed only for contracting, or does the IPA provide grant research for clinical studies? Ability to help you with better contracting. Is the IPA actively involved in going after value-based contracts? The IPA should be your organization that's leading to help you get more business, save money, and provide better quality. It's not about them. It's what are they going to do for you. So ask them what services are they going to provide to you to help you become a better doctor and make more money. That's why I would recommend it for that.
Excellent.
So you have a second question?
We do. We have another question here. This one's asking you to look into a crystal ball for us. How do you see the healthcare industry evolving over the course of the next 5 to 10 years? What do you think is next?
Well, as we kind of talked about, it's obvious that the reimbursement system is going to be changing. Maybe not for the right reasons, but somehow we have to put the patient involved in their own health care. There has to be some incentive for the patient to get healthy, to participate. You think about your car insurance rates are based on how well you drive. The more accidents you have, the more you pay. You think of your life insurance payments. It's based on your lifestyle. If you smoke, if you've had 3 heart attacks, if you're overweight, your life insurance is based at a different price. On healthcare, the healthiest person and the sickest person end up having the same cost to them. And therefore, people that are unhealthy, besides that they just want to become healthier, have no financial reason to follow protocols. Somehow we got to change that. And to date, the government has mostly been talking about what we need hospitals and doctors to do to help cut the cost. They're not putting any incentives on the patient. And I think they want to say health care, you're entitled to health care, but you're also entitled and required to have car insurance. We've got to find a way of putting the patient and their family back into this and not making the physician the only one that's financially responsible for cutting costs. As chronic disease is increasing, the cost goes up. It's not the doctor's fault that chronic disease is increasing. It's not the doctor's fault that childhood obesity is increasing tremendously. It's got to be the family, the patient, the community. Somehow we got to push that. Until we do that, there's going to be constant pressure for lower payments to physicians to take care of the patients, up to a point where my daughter was pre-med when she first started in college. She's decided she doesn't want to be pre-med anymore because she doesn't believe, from talking to the professors, that healthcare is the best place to go much further. So I think that's the thing we got to change. We got to get people excited about keeping people healthier, but the patients have to participate too. And part of it might be getting the families to encourage those patients to be more involved in helping their own health instead of relying on the doctor to do everything for them.
Very good. Thanks for your insight on that as well. Let's take just a brief moment. We'll put the poll results up. Allow it. And we'll review those briefly. Thank you for your input and response, all of the live attendees. You'll see, of course, with pick the top 5 that worry you most out of the top 10. On the top of that, the changing reimbursement model from fee or service. That one, of course, being rather salient to today's topic. We appreciate that feedback. Mark, do you have any comments specifically to the poll?
It's funny. I was looking at this poll, and again, there's this national polling, what people thought, and this poll here almost looks the same because the number 1 is changing reimbursement. The number 2 is high deductible. Number 3 is claims denial, just like you have here. The other one, I think, that is a little further down was the consolidation of healthcare plans and how that's going to affect things. I do believe that's going to be a big factor because most payments still come from healthcare plans, although it's a higher payment to the patient now, but they're still on a healthcare plan. As they combine and they become bigger and stronger, to fight against paying doctors a better fee. That's why I think it's hard for a 2-doctor practice to compete out there. When you have to negotiate contracts with these large healthcare plans, that's why, again, I always believe in MSOs and IPAs where you can get doctors together to provide more strength to compete for a lot of this business going forward. But it's interesting, like I say, the poll did kind of match exactly what our national poll showed as far as what was the most important things that are keeping doctors up at night.
All right. Well, thank you once again, Mark, for your time and your knowledge today. Really appreciate it. We'll now turn our attention to Ms. Bobby Abbott from Care 360, who will deliver a brief presentation on our comprehensive offerings. Please feel free to continue to use the built-in Q&A functionality if you have any questions about Care 360. And with that, Bobby.
Thank you, Colby, and thank you, Mark, for sharing your expertise and your insight with us. As Colby mentioned, I'm just going to be spending a couple of minutes talking about our Care 360 solutions and what they can mean in your practice. We primarily have built our solutions and we continue to develop in our solutions with the patient in mind. So our focus is to offer you all technology solutions that continue to increase your efficiency, and so ultimately you can focus on the health of your patients. And I'll just give you a brief view of how that looks. Our Quest landscape is very broad and wide. Quest Diagnostics is a Fortune 500 company focused on improving the health of patients through diagnostic insights, and we use those insights to help drive action. Where Care 360 comes into play, Care 360 is our healthcare IT arm of Quest Diagnostics. And between our labs and meds products, our Care 360 solutions, and e-prescribing, we have access, and we do have 420,000 physicians have access to our tools in our community in over 125,000 locations. So the Care 360 network is really the recognized standard for fast-efficient and powerful connectivity. As mentioned, we do have a very broad-reaching footprint in the U.S., and we're a very valued and well-known brand across the healthcare industry. Here's just a quick visual of how our solutions work in synchronicity to help manage your practice. So really from the second the patient walks in the door through their billing and remittance and follow-up dialogue with the physicians in the practice, we offer that whole spectrum of service to you. Quest Diagnostics initially started with our labs and meds solution, and this was designed to help ambulatory physicians place lab orders and review results electronically. And then we added our e-prescribing module, which is a module that allows you to write and manage prescriptions electronically. Within e-prescribing, we also do offer a DEA-certified electronic prescribing of controlled substance solution, as well as a patient-centric solution called offers. So when a vendor or manufacturer offers discounts or incentives for their particular medications, those offers show up seamlessly in our e-prescribing solution, and you're able to easily transfer those savings on to the patients. And a lot of the collaboration between the practice and the physician is managed through our MyQuest patient portal. Within Care 360, we also offer an array of solutions to help you manage your practice. We have our Care 360 electronic health record, our practice management solution, and our revenue cycle management solution. And I'll speak to all of these components in just a moment. First, our electronic health record. Our electronic health record is a cloud-based solution. You can really take it wherever you go with our mobile solution and offering. Electronic lab orders and results and e-prescribing are all available within our electronic health record. So, for example, if you used Quest Diagnostics Labs and Meds for your lab and med solution, all of that patient information would be available to you within our electronic health record the day that you implement our solution. As mentioned, we do have secure mobile access via iPad, iPhone, and Android applications. And the MyQuest patient portal that I had just mentioned is integrated right within our solution. So we do offer a comprehensive, fully mobile and secure EHR, and it is, of course, ONC certified technology. So as the demands for the incentive programs continue to increase and push on us, we do offer a solution to help you manage through those, and we're continually developing to stay ahead of that as well. Our practice management solution is really a flexible billing and scheduling solution that's integrated directly within our Care 360 EHR to meet the needs of your practice. What's nice with our solution is that it is fully integrated. You do have transparency and visibility into your practice performance. There is customized scheduling and reporting. It is a flexible solution, so you can really right-size it to fit the needs of your practice. With all of our solutions, if you're using a different PM solution, but you are looking for an EHR provider, we do have the flexibility to help build and expand your landscape in various ways because of our integration and our technology and our footprint. We do take it one step further for practices that don't have the resources in-house or have been thinking about outsourcing their billing. We do offer revenue cycle management. So it's truly a full billing solution. We provide not only the software, but the people and the support and really everything you need. So if you chose revenue cycle management, we take care of all of the billing for you. So you would have somebody to work with you hand in hand to get you up and running. You would have complete transparency into your financial performance through our dashboards and comprehensive reporting. Our folks on the revenue cycle management side take care of all of your billing and denials and follow-up. And the solution is fully compliant with HIPAA, OIG, and ICD-10. And when you choose revenue cycle management as your complete billing solution, it does include access to electronic health record, and it's a fee for service. So basically, we take a percentage of your collections, and it's really that one fee for all of the holistic solutions that work together seamlessly. And really, as I mentioned, with Quest Diagnostics, you're getting the whole footprint and the whole breadth of the solutions that we provide. So we are true to really integrating providers and technologies across the care setting, across communities. We can easily and securely help you exchange patient health information. We are part of the accredited Direct Trust Network. We do use CCDA industry standard technology to share information across providers, and we do have access to extensive patient lab histories to help you optimize care. So you can truly coordinate care to and from anywhere and focus on really the big picture. And when you invest in Quest Diagnostics, you are investing in, as I had mentioned, a Fortune 500 company. We are very financially stable with $7.5 billion in revenue in 2015. As mentioned, we do service about 420,000 physicians in over 125,000 locations. And we touch the lives of over 30% of American adults every year, so we are very broad and wide. You can deploy our solutions quickly with our nimble approach, and again, it can be customized to fit your specific needs. So if you need to keep parts of your practice IT solution intact, and you might be looking for a new EHR or a new billing system, we can easily integrate across that spectrum. And when you choose Care 360, you are really getting a world-class US-based implementation and support team to help thoroughly assess your needs, help you determine what you need, and make sure that we're there for you when you need us. I just wanted to take a moment to mention KLAS. Some of you may have heard about KLAS before. They're a third-party research company that focuses solely on healthcare technology. And these are a few of the comments that speak to what we're hearing out in the industry. KLAS does conduct confidential interviews, so we don't know where these comments have come from other than our customer base. And this really echoes the fact that Care 360 is simple and easy to deploy. It's easy to use. And with our revenue cycle management solutions, it does the billing for you. And Colby, I am going to hand it back over to you. Oh, let me mention one more thing. Our practice management and our revenue cycle management solutions are available as standalone. So even if you want to go with a coupled approach, or if you don't want to, again, that integration and the ease of workflow based on our integration and our foundation, it's easy to make it happen.
Excellent. Thank you very much for that, Bobby.
Sure.
A couple more questions have come in on the Q&A. We'll keep Mark on the hot seat for the moment. We have, hopefully this one's a softball. Have the specifications for the macro program been released yet, and will these be implemented in 2017 or 2018?
The preliminary ones have already come out. Everybody's reviewing those today. Not a lot of major changes, but new quality indicators. We believe that I think part of it's going to depend on the presidential election, on how fast this thing really does get rolled out. Right now, we're probably looking at 2007, 2018, but that all could change depending on who wins the election.
Excellent. And we have another quick follow-up for you, Mark. I liked your comments about patients needing to be responsible for their health. How then is it incumbent upon physicians to supply so much documentation to show this rather than the patient?
Yeah, that's the problem today, I think, is that everybody's relying on the doctor to do everything. And then if the patient's not compliant, they don't follow through, you know, the patient's not penalized for that. You tell the patient they need to go get a lab test done, or they have to go get an MRI done, or they need to go pick up these medications, and they don't do it. You know, that's their fault, not the doctor's fault. Yes, you should check up on them to make sure they did get it done. But if they don't do it, then doctors should not be penalized for that patient's outcomes not being what they should be. And I think that needs to be built into all these value-based reimbursement models, is the ability for the physician to track those patients that are not compliant, and you should not be penalized for non-compliant patients. I'm not sure how the government's going to, or anybody else is going to be able to meet that requirement, is making the patient do it. But it's very easy for the healthcare plans. They come back and say, patient, if you're not compliant, you're going to pay a higher rate for your insurance. You're still entitled to health insurance that way. You just get your health care, but we got to put some responsibility back on the patient, and financially is the best way to do it. I would, you know, create almost a two-tiered financial system. Patients that are compliant pay one rate, patients that are not compliant pay a different rate, or that their deductible is much higher if they're not compliant. Somehow putting a financial burden back on the patient to follow the protocols the doctors have set for them.
That makes a lot of sense. And I know we also look forward to greater advances in technology as far as our integration with patient portals as well to create some of that responsibility and to make sure that it's easy for them to comply.
Being
sensitive. Sorry, go ahead.
Getting information coming from the home. I remember going back to the home of the future up in Microsoft about 10 years ago, where the refrigerator was sending information to a pretend doctor about what the patient was eating and what they were putting in the refrigerator every day, and little things like that. Or the electronic pill box that tracked how many times when a pill was taken out of the box, because it actually weighed how many pills. You got 12 pills. When that one pill came out of it, it knew exactly when it came out. Didn't know if you took it or not, but it did know when the patient was taking the pill, and it was sending alerts to, in this case, the grandma saying, don't forget, it's 2 o'clock and you haven't taken your medication yet, like a little note to them telling them to remember to take their medication on time. So you can help create more compliant patients by high touch, and electronically is the best way to do it, especially as more and more people move to smartphones.
Very good. Well, being sensitive to everyone's time, we have time for one more question here. One more that came in on the Q&A, and this one will head towards the Care 360 team. For practices interested in patient-centered medical home certification, will Care 360 EHR meet their needs? Bobby, perhaps you could address that?
Colby, I am actually going to delegate that to our Care 360 resident expert, David Mills. David is on the line with us. David, if you can answer that, that would be wonderful.
Sure, absolutely. Good afternoon, everyone. So whether it's a patient-centered medical home or an ACO or other large group, it really comes down to needing access to information. And we are already working with large groups to provide data feeds. So, for example, we have ACOs where some of their membership uses Care 360 EHR. We get together with the ACO leadership team, understand what data they need, and we provide a data stream to whatever population health management software that they may use to do the reporting and slicing and dicing of data. So, yeah, absolutely, we can help you out.
Excellent. All right, one more quick one. We're squeezing it in. What tools does Care 360 currently offer to support a value-based reimbursement model? Also very salient to today's topic.
Sure, and I think we offer lots of different tools within the product, and it depends on where the provider's at as far as participating in the value-based reimbursements. But it's everything from population compliance, understanding the different populations in the office, which patients are non-compliant and due for certain services. It's getting alerts in the patient schedule for care recommendations. We also support meaningful use reporting. Part of that requirement is clinical quality measures. We have PQRS functionality that's available to our customers. And then again, just mentioning the larger groups being able to connect and provide a data stream to provide them with that information. So we can kind of meet you where you're at and help you qualify for your value-based reimbursements.
All right. Once again, we thank you all for your attendance today, and special thanks to Mark Anderson and Care360 for sponsoring the event. Please keep an eye on your email inbox for additional presentations covering related issues in the very near future. And this will conclude today's presentation.
Healthier outcomes are now easier to embrace. We know you run a busy practice, and efficiency is top of mind. Discover 360 degrees of connection and support. Keep your practice on solid ground with a cloud-based EHR.
Care360 offers a full and fully mobile EHR that helps keep medical practices efficient and profitable,
while connecting to the larger healthcare community.
Join the network of over 300,000 Care360 providers in 90,000 locations and connect to other healthcare providers as well.
Coordinate care to and from anywhere.
Care360 integrates providers and technologies across sites and care settings,
while seeing and sharing the bigger picture.
Care360 allows you to send patient information using the CCDA industry standard format, accept information from other providers, and access extensive patient lab histories to help optimize care.
Meet meaningful use requirements.
Care360 EHR is ONC certified to qualify for meaningful use,
while exchanging data simply and securely.
Physicians collect and share data with other EHR users to meet industry requirements with Care360 Data Exchange.
And with new Care360 Revenue Cycle Management, you can maximize collections and revenue.
Care360 provides you with a team of billing experts to take complicated billing issues off your plate, allowing you to focus on what matters most, your patients,
while reducing your administrative burden. And that means more time with patients. Care360 also offers many other great advantages. Boost patient engagement and compliance with MyQuest.
Patients can view and share vital health information with their healthcare providers.
Elevate patient conversations with interactive insights.
Enhance lab results with diagnostic insights, accessible in Care360 and to patients through the MyQuest patient portal.
That's 360 degrees of connection and support, and healthier outcomes for all. Care360.